2, 1. Please start. We are live.
Good evening, namaskar, and good evening, everyone. I welcome you all for today's webinar on optimizing treatment outcomes in lung cancer. With immense pleasure, I would like to invite Dr. T.P. Sahu, who is Senior Consultant Medical Oncologist, Silver9 Hospital, Bhopal, to do the introduction and welcome and to carry out the further proceedings. Over to you, sir.
Good evening, everyone, and thank you, Astra, thank you, Strands, and thank you all friends, colleagues who have joined on a working day evening, time away from the family, at least for the next 1.5 hours. So I think although the meeting will carry a significance because we are going to venture into treatments which we normally don't discuss, especially the panel of Dr. Tejinder should be an interesting one, which will include all the faculties of radiation, surgical, and medical oncologist, and I think he will be discussing the newer facets of treating operable lung cancer. So without much of delay, I would like to invite the first speaker, Dr. Nikhil, who's an accomplished medical oncologist from Nagpur. And Nikhil, I don't think he needs any introduction at this point of time. He will be speaking on the changing paradigm in the treatment of resected non-small cell lung cancer and mutation positive. So Nikhil, are you there?
Yes, sir, I'm there, sir.
Yeah, and you would like to share your slides?
Sir, I think Aram will share it for me. Aram, have you got it?
So Aram, can we have the slides of Dr. Nikhil? And Nikhil, 10 minutes. I would request all the speakers to stick to time. Don't go beyond the time limit so that the panels can have a good discussion after that. Dr. Nikhil.
Yes, sir. Thank you. And without much ado, I'll just start because it's only 10 minutes. Today, I'll be talking about the newer paradigms in the treatment of resected EGFR mutated early lung cancer. Next slide. So 1 in 3 patients in NSCLC present with resectable disease. This is definitely not Indian data, but is the leading, this rest of it we know. Next slide. So outcomes definitely needs improvement, and surgery is the primary treatment for patients with early stage NSCLC. I'll be talking about 1B, 2, and 3 most commonly. And adjuvant cisplatin-based therapy is the recommendation for patients who treated stage 2 to 3 NSCLC with stage 1B disease also. And overall disease recurrence or death following surgery and adjuvant chemotherapy remains high across the disease stages. Next slide. So what is the 5-year recurrence rate by stage? In 1B, it is 45. 2B, resected regional locally advanced, it is 62 versus 76% if it goes to stage 3. Next slide. So based on a limited number of studies, the presence of EGFR mutation appear broadly similar across the disease stages, where overall estimated prevalence in Asians is around 30 to 40%, with Caucasians being 10 to 20%. And I don't know, but obviously the stage-wise, the prevalence will not change much. But if EGFR TKIs were available in the resected settings, a similar proportion of patients may be able to benefit compared to the advanced setting. This is what I mean by this slide. Next slide. So this was the EDURA trial, which talked about osimertinib as adjuvant therapy in patients with stage 1B to 3A EGFR mutation positive NSCLC after complete tumor resection. Next slide. So I'll just talk about this slide in detail, where EDURA was a phase 3 study, which included the key inclusion criteria was more than 18 years, WHO performance status 0 to 1, confirmed primary non-squamous NSCLC, exon 19 or L858R, brain imaging if not completed preoperatively, complete resection with negative margin, and max interval between surgery and randomization, 10 weeks without adjuvant chemotherapy and 26 weeks with adjuvant chemotherapy. And stratification was by stage, EGFR status, that is exon 19 versus 21, and race, Asian versus non-Asian, were randomized into osimertinib versus placebo and planned treatment duration of 3 years, with treatment continues until disease recurrence, treatment completed, or discontinuation criteria met. Follow-up until recurrence, week 12, 24, then every 24 weeks to 5 years, then yearly. After recurrence, every 24 weeks for 5 years, then yearly. Next slide. So the key inclusion and exclusion criteria are staged as 1B to 3A, central confirmation of mutation. Standard post-operative adjuvant chemotherapy consists of a platinum-based doublet for 4 cycles maximum, was allowed but not mandatory. Complete surgical resection and CT or MRI of the brain prior to surgery, and performance status of good performance status. The key exclusion criteria was prior treatment with pre or post-op radiation, pre-op chemo, EGFR TKIs, or any CYP3A4 inhibitors less than 3 weeks prior. Time between surgery and randomization not more than 10 or 26 weeks. And patients who have only segmentectomies of wedge resection, and cardiac criteria including factors that will increase the risk of QTC prolongation or any arrhythmic events, any evidence of severe or uncontrolled systemic disease, and medical history of ischemic lung, interstitial lung disease, or any other malignancies. Next slide. So I'll skip the patient characteristics. They were mostly matched, and even the adjuvant chemotherapy, yes, no, between the osimertinib and placebo arm was almost similar. Next slide. So this was where osimertinib, the ADURA trial, DFS, which was the primary endpoint, versus placebo in resected EGFR mutated NSCLC. You can just see the curves and no need for any explanation. The hazard ratio are hardly 0.17 and 0.20 in the primary population as well as the overall population. Next slide. So there was an 83% reduction in risk of disease recurrence or death with osimertinib, and in the overall population, 80% reduction. Next slide. So if you look at across the stage, the 2-year DFS was much better in the osimertinib arm as compared to the placebo arm, with the hazard ratio being highly significant. Next slide. If you look at the subgroup, rarely do we see a waterfall plot where everyone has benefited, regardless of what is it. Everyone, it's on the left side, all the curves except stage 1B, where understandably it is a little closer, and L85 does a little worse than EGFR exon 19 deletion. Next slide. The one slide previous to that. So early snapshot, overall survival in patients with stage 2 to 3A, although the data is yet to mature, but still, even in this, the hazard ratio has started showing benefit towards osimertinib, and patient and investigator remain blinded to treatment in order to facilitate assessment of OS at maturity. Next slide. So EGFR TKIs in the adjuvant settings, NSCLC, DFS, but not OS benefits have been demonstrated. There have been various studies, but all of them come with some riders. Next slide. In ADURA, the another thing which happens is the type of recurrence is a key consideration in resected NSCLC. In next slide. So if you look at the ADURA, 11% of the osimertinib arm had DFS events versus 46% of patients in the placebo arm. And in the osimertinib arm, majority of patients with recurrence had local or regional recurrence only, with only 38% of the patients having metastatic recurrence compared with 61 patients in the placebo arm. What I mean by this is, if obviously a local recurrence is a easier to treat recurrence as compared to a metastatic recurrence. Next slide. And if you look at the CNS as a site of disease recurrence, which is obviously gives a very bad prognosis, it is much less in the osimertinib arm because it has the highest brain penetration in the TKI sectors versus in the placebo arm. Next slide. So the same thing. Next slide. If you look at the CNS DFS in the overall population, obviously, since the CNS recurrences are less, the CNS DFS is going to be very high. Only 1% had a CNS recurrence. Next slide. Now, the last of it, safety summary. Is there anything which is very strikingly different? Next slide. So basically, we should understand that many of these patients have been post-adjuvant chemotherapy. So they will have some residual side effects of that persisting. Other than that, grade 1 to 2 interstitial lung disease was reported in 10 or 3% of the patient of osimertinib arm, and QTC prolongation was reported in 7% of the patient in osimertinib arm and 1% in the placebo arm. These were something which striked apart. Next slide. So post-operative chemotherapy use and outcomes from ADAURA. Osimertinib as adjuvant therapy for resected EGFR mutated NSCLC. Next slide. So overall, 60% of the patients received adjuvant chemotherapy for a mutant duration of 4 cycles, and majority of the patients received platinum-based chemotherapy, most with stage 2 and 3A disease. And adjuvant chemotherapy was more frequent in patients aged less than 70 as compared to those above 70. Next slide. So 1B patients were less treated with adjuvant chemotherapy as compared to the other arm. But DFS in patients with or without adjuvant chemotherapy, if you look at both the arms, so irrespective of the fact whether they received adjuvant or chemotherapy or not, the DFS improved. Next slide. And if you, again, except in 1B where it approaches close, in rest of the 2 and stage 3 disease, it doesn't matter with or without adjuvant therapy, osimertinib did benefit all of them. So it is not only the adjuvant chemotherapy which is helping out, or because it was matched in both the arms, but it was the osimertinib which is giving them the DFS benefit. Next slide. Next slide. So DFS in patients with and without adjuvant chemotherapy, I'll just talk about stage 2 more than anything else. You can just see both the curves are so wide apart separating that even without adjuvant chemotherapy in stage 2, although it falls slightly, but it is still significantly better as compared to placebo arm. Next slide. Similar things in stage 3A, although the number of events or patients who did not receive adjuvant chemotherapy was less, so number of events were less, so data is not exactly very telling, but yes, the DFS benefit persisted. Next slide. So patient-reported outcomes. Next slide.
One more minute, Nikhil.
Yes, sir. I'm just about to finish. So what were the patient-reported outcomes? This is a quality of life methods where, next slide, HRQOL SF36 survey was used. And if you look at that, the compliance rates with SF36 survey were high in both osimertinib and placebo arm, and both arm almost overlap each other. Next slide. And the time to deterioration of physical and mental component, both the osimertinib as well as the placebo arm, they're almost on top of each other. Next slide. So by that, I'll just summarize. Adjuvant osimertinib is the first targeted therapy in a global trial to show a statistically significant and clinically meaningful improvement in DFS in patients with stage 1B, 2, and 3A EGFR mutated NSCLC. Overall, there was an 80% reduction in risk of disease recurrence or death with osimertinib. Osimertinib versus placebo DFS rates at 2 years were 89% versus 52%. It demonstrated a clinically meaningful improvement in CNS DFS compared with placebo, and the safety profile was consistent with established safety profile of osimertinib with mild EGFR TKI side effects reported. Next slide. A clinically meaningful DFS was observed with or without adjuvant chemotherapy. Higher disease recurrence rate in placebo arms who received adjuvant chemotherapy to those who didn't, likely driven by a large proportion of patients with stage 2 and 3A, as disease is a prognostic factor for disease outcome. And overall, the quality of life indicators showed no meaningful deterioration in quality of life with osimertinib. So the ending thought is adjuvant osimertinib will provide a highly effective practice-changing treatment for patients with stage 1B, 2, and 3A EGFR mutated NSCLC after complete resection. Thank you.
Thank you, Dr. Nikhil. I think this does make a case for all of us, at least in the patient profile, which were as per the ADURA trial, to be offered adjuvant osimertinib if there's EGFR positive operated patient who come to us. And the point that is a take home, I think that what Nikhil emphasized, irrespective of the adjuvant chemotherapy, the advantage of the adjuvant osimertinib was there. And I think it does make a point to discuss, at least with the patient, the cost, the benefit, that all things. And definitely all of us would like to look at the OS survival. But whatever data is there till now looks very impressive. Thank you, Dr. Nikhil.
Thank you, sir. Thank you, sir.
Yeah. So I think now we move on, and we have early stage lung cancer patients. It's a case-based discussion, and I invite Dr. Tejinder, who's a friend, colleague from Mumbai, who's a senior medical oncologist, and the panel, Dr. Gaurav Gupta, is radiation oncologist from Bhopal. Dr. Praveen will not be there. He has sent his apologies. Dr. Vinod Dhakad, who's a surgical oncologist at Indore, he is there, and Dr. Vikas and Dr. Sameer, both medical oncologists, respectively from Indore and Nagpur, will be there. So, Dr. Tejinder, please.
Yeah. Thank you, Dr. Sahu, for inviting me. So we will keep our discussion mainly to stage 1, 2, and try to touch a little bit about the stage 3 also. Thank you to the panelists for joining. So this is what is very important to understand about our lung cancer scenario. You can see the 5-year overall survival, and it's something which is very important because the survival is too good in the first stage. That's a different topic that we'll discuss about how common it is. And the survival start dropping from 1B onwards, and by stage 3 it is hardly 20%, and we know what is the outcome in the stage 4. So this is a hypothetical case. A 67-year-old male non-smoker presented with mild cough. An X-ray showed a very small lesion in the left upper lobe, and CT was done, which showed a left apical lesion. So then later on the PET scan was done. You can see a PET scan lesion in the left upper lobe, and a small lesion, and you can see a surrounding lymph nodes also, but they were not so bright enough. So the PET scan finding showed that there is a very well FDG avid lesion in the left upper lobe with adjacent pleural tags and non-specific reactive nodes in the prevascular area. And important thing was that there was no distal metastasis. So I will start directly with the question to my surgeon colleague, because these are the cases which will directly go to them. Dr. Vinod is here now. So what we will do now, directly we will go 67-year-old, what kind of counseling will be going ahead, and anything else you will do prior to doing a surgery?
Yes, sir. Obviously, the patient is the age of the patient is 67 years. So first of all, we should see for the performance status of the patient, and if it fall in the 0 or 1 performance status is good, then we can go ahead with a pulmonary function test. And in this kind of the cases, we need not to go for biopsy and some invasive biopsy. We can go ahead with planning of definitive surgery. And in that case, we can manage by after doing all the preoperative requirements. If the patient is fit for surgery, then we can take the patient for surgery. First, we have to sample some lymph node from the mediastinal. If these comes out to be positive, that to be N2. So then, uh, then
So, Dr. Vinod, you are telling that biopsy is not a must in these kind of cases?
sir, if the patient is having clear-cut surgical means, if we are having the facility of frozen section examination, then
So
we can
this
avoid
patient,
biopsy.
yeah, that is what I'm telling you. This patient has got a very well-defined FTG avid lesion, which is nearly 7 to 8, and not 8, I'll say around 15 to 20. With so what I was saying is that biopsy, I feel most of us do it medico-legally also as a must procedure. Normally, we don't go ahead with the surgery, right?
Yes, routinely we do follow this thing, but if the patient is having clear-cut operable lesion and the patient is totally fit, then we can do what we can do. We can have a VATS, means video assisted.
Awesome. Yeah.
We can have intraoperative cytology and we can proceed with that.
So in your practice, how much help you are taking from the pulmonologist regarding EBUS, or you do only yourself medicinoscopy?
No, sir. We usually follow the EBUS only. We rarely do mediastinal.
Yeah. So basically, what I was telling is that prior to doing the surgery, you will be doing an EBUS.
That is also to be recommended during the definitive GA, means the patient is in OT. We may avoid multiple procedure on the patient in that case. So we can take the patient in the OT. First, we can do EBUS.
No, what is your normally your routine practice? Because these lesions are not like looking like any kind of emergency. You have ample time to decide what you want to do. There's nothing in emergency here. Here everything is elective. So what in your clinical practice, you do not tell कि मैं सब कुछ एक दिन ही OT में करूँगा. Normally you go ahead and do a EBUS, do a biopsy, then plan the surgery accordingly to it, right?
Tejinder sir, Dr. Samir here.
Yeah.
Can I interpret for a few minutes?
Yeah.
So I want to highlight one point here. So means I want surgeon's opinion here. If you see the stations of lymph node, which can be targeted by EBUS, I think what I remember, only 3 stations cannot be targeted by EBUS.
Yes.
Which can be targeted on mediastinoscopy, and these 3 stations doesn't make any difference in surgical management.
Right.
So even if you miss that lymph nodes on EBUS, that is not going to change your surgical management. So that's why the practice has changed from mediastinoscopy to EBUS, which is much less invasive.
Even
so this is my understanding. I think
even this is my yes. Even I feel this is the understanding. That's the reason why I said this surgery doesn't require any. You can go electively in a very slow fashion. No need to be in a hurry to do everything at the same time. So, Dr. Vinod, just wanted to ask me. I'm asking nowadays. Doing this intraoperative mediastinoscopy and EBUS, how much you have seen the practice changing in the last 15 years? Now, I think every center has got EBUS doctors.
Basic practice is like that. What you are mentioning, the patient comes to us, then we first send the patient for EBUS and do the. But the patient is totally fit and lesion is looking like operable upfront, and the lymph nodes, they are not FDG avid and not looking on radiologically and PET scan wise they are looking means negative. Then we can go upfront with intent of definitive surgery, and then we can plan accordingly in the OT. If there is some doubt, then definitely we have to send the patient for EBUS and the staging of the mediastinal and lymph node, and then the staging wise we can manage the patient.
Right. But so one more question to Vinod. In your practice, how many in a 6 month? I'll just asking you. I know you are coming from a very busy place. In a 6 months, how many patients you have operated for stage 1 and stage 2 CLR?
I have not operated.
Yeah, that's very important because I am asking 6 months. I'm not asking 1 month.
It was clear-cut operable type of patient, but rarely we find these kind of patients. Rarely.
Yeah. Samir, how common you have in a year? How many patients you are given adjuvant therapy, stage 1 and 2? The other way to ask question to you for a medical.
Sir, in last 1 year, na. So you could have asked last 2 years, so I could have said one patient. So in last 1 year, not a single patient.
Right. That's very important. That is very honest answer. Huh? So
Yes, sir.
same question to because how many in a year I will say adjuvant chemotherapy?
So to be very frank, sir, pre-COVID the number was 0. During COVID, 2 patients, and those patients was also detected like the CT scan was done for different reason.
Yeah, right. It's something very. Achha, now question is for to our radiation uncle Gaurav. Now everything is changing the whole way. I'm just talking about stage 1 and 2. Do you think with so much new data coming, I think there's a trial also which has totally taken out the PORT out of the picture. You still think that there is a role of post-op radiation in a stage 1 and 2? I'm not talking about 3, honestly. 3 is a totally different disease.
So as such, there is no role in what I would say, only in case margin is positive, in only that subset it is required. Otherwise, as such, there is no role.
Right. I agree with, that is what I asked you the first question about how often we see. Honestly, in 1 year, I had given only one adjuvant chemotherapy, and very uncommon to see patients, and it depends upon the centers. One of my colleagues is there in Asian Cancer Institute where Dr. Raman Deshpande is there. They do tend to get slightly more number of patients as compared to me. So I think we are quite okay with certain things. Nowadays we are doing PET scan almost for every patient. We do go ahead with the tissue sampling. We do the biopsy. My question to all of you is that in this patient who is early stage cancer, how many of you are doing MRI brain? Samir?
Sir, each and every patient we are doing.
Each and every. Vinod, I think Vinod is the main person.
If we are planning for surgery, then we have to do, sir.
Yeah, that's very important. So, because I think you are doing for everyone MRI.
Yes, sir.
Brain?
So if patient is going for surgery or definitive CTRT, I think MRI is required.
Right. Gaurav, I think any change of thoughts, or you believe in the same thing?
Sir, less than 3 centimeter, I don't go for MRI, else I go.
Okay, less than 3 centimeter, you're talking more of a T1, basically.
Yeah.
1A. Yeah. So I think it's a very nice thing which Gaurav said. There are some centers which are not doing it for a 1A. But most of us are doing the baseline MRI prior to going ahead with the surgical. Any surgery patient, we normally do it. It's a very funny disease. So Gaurav, you feel that the biopsy is a challenge for early lung cancer? Or there was a time people used to do FNAC. Agree, nowadays almost all of us are sitting in a city. That's, I think, it becomes very easy for us. Or still you feel it's a challenge?
No, it's not a challenge in present era. It's fit comfortably.
Okay. Vinod, can you just tell us about, you have described about mediastinal staging. Samir mentioned about the EBUS, that there are 3 stations which are not possible to go ahead and do the biopsy from with the EBUS. But honestly, end of the day, it will not make any change in the treatment, right? So you think EBUS still basically holds ground, or I think there are still challenges with the EBUS also? Vinod?
Yes, sir. There are challenges because most of the person in EBUS, they are doing only FNAC. They are not taking definitive tissues. In early stage cancer, non-small cell lung cancer, we need biopsy for further testing of the
No, but EBUS, they do the biopsy. The needle is quite big enough to take a biopsy. It doesn't do the FNAC.
They do, but sometimes they do some FNAC only.
Okay,
This
so
is
basically,
this is the main drawback, I think, in EBUS as compared to mediastinal. But mediastinoscopy is invasive, more invasive, and more surgically means challenging thing. And routinely, most of the people are means reluctant doing mediastinoscopy.
okay, fine. But I think, to my knowledge, almost wherever I am practicing now, in the last few years, I think everyone has gone away from the mediastinoscopy. They rely a lot on the EBUS. And there are now good number of centers which are doing it, and good number of trained people, I will say, who have started doing it, and they mention all the stations very nicely. Yeah. So they mention very nicely all the stations when they are taking the biopsy, and it is very helpful. And like I said, there is no emergency here. Everything is elective. We need not rush the things very fast over there. So these are this patient underwent EBUS. There was no enlarged mediastinum, no physically fit, underwent surgery. Now, the post-surgery, the specimen you can see, it was basically a T2 lesion and invasive adenocarcinoma, and there were around 2 nodes, station 10 and 11, they came positive with metastatic deposits. Now, what are the next steps? My question to all my medical oncologists and Gaurav also is that, do you do any molecular marker in this kind of patient, and if which type of molecular marker, whether you go for a extended panel or you just do a limited panel? Vikas and myself are both sitting in the home. I think only person who is working still is Vinod, very busy man. And I think Nikhil is also there, and Gaurav is also in the home.
अरे समीर को भूल गए तुम.
Sahu, I think, is also in the clinic.
Sahu is at home
Samir
relaxing.
is also so very important, because in an elective case you have ample time to decide which marker you want to do it. Because
yes, sir. So like as far as the treatment part is concerned, we know that the only approved we have approval only for osimertinib, that is like patient has to be positive for EGFR. But
you will not send anything else?
Yes, sir.
Only EGFR?
So that's what I am telling, sir. I will send the whole NGS that might my patient benefit, like if some trials are ongoing, adjuvant trials are ongoing.
अरे adjuvant trial में सिर्फ ALK और EGFR का चल रहा है और कुछ नहीं चल रहा.
That's what, sir. If positive for ALK, I can send for trials.
Okay. So Gaurav, what you do?
Usually EGFR.
EGFR. Samir is there.
Sir, PD-L1, CPS score and EGFR, these are the only have therapeutic implication. Otherwise, you can do NGS, but it will not change if there is any other mutation. It may help in future management. So it is not wrong in doing that, but immediately it will not help us. Only EGFR and PD-L1 will help.
So that's a big problem happens. One of my patients, basically somebody had done an extended panel, ALK came positive, and it became like a big issue. But still, anyway, we gave adjuvant chemotherapy, and after discussing with the family, we had no other choice but to give crizotinib to the patient also. She's doing very well. I think Nikhil and myself both have treated that patient. So it becomes very difficult. I know that Alchemist is still doing it, but right now the guideline talks only about 2 things, PD-L1 and the EGFR. Dr. Vinod, I think this is, I know the surgeon's area is a little bit away from here, but we normally send all those things. So because you feel that in the future, extended NGS might help?
Yes, sir. So like we have precision oncology drugs, and like in metastatic setting, they are slowly infiltrating in adjuvant settings, sir. And they are wonderful drugs, very active, efficacious drugs. So I don't find any reason why they will not be benefiting our patient in adjuvant setting. So it's just a matter of time, sir.
Yeah. One small question to you is that, you think I am talking about medically fit patient. If you have 10 patients who are early lung cancer, stage 1 and 3, how many of your patients ultimately undergo surgery? Vinod, you are the only surgeon. I cannot ask Vikas to take the patient for surgery. And you have to unmute yourself. Because Vinod, you have to unmute yourself.
Vinod, you are
Yeah. So how many percentage of your patient undergo resection ultimately?
Ultimately, resectable cancers, they are basically, I have encountered only the young patients, the operable patients. Those came to me, but I am not I am not practicing as a whole oncology, like so I am not getting all kind of lung cancer, so that I can separate them operable and means higher stage. I usually get patients from the medical oncologist side.
So basically medical oncologist पूरा छांट बांट के आपको ऑपरेट करने के लिए ही बोलता है. Non छांट बांट he doesn't give it.
खाने का काम वो करके
So
देते हैं.
you have a very good medical oncologist who sends you patient. Anyway, that's a very good thing.
Yes.
Okay, Gaurav, I think this is a question for you. I think you have answered about the post-op radiation early stage. Any role right now in the present era except for the margin positive, right?
Sir, no other role. In
No other
case
role.
any other high risk factor is there, it's better to go for adjuvant chemo.
Okay. Some patient, they do not want surgery.
Yeah.
How much is the role of SBRT and proton? I'm talking about proton.
Sir, for sure, a patient not willing for surgery or medically not fit for surgery, in that particular case, early stage should go for radiotherapy, especially SBRT.
Okay. What about the role of proton? So much now people are talking about proton now. You feel proton is better than SBRT?
Sir, proton is definitely better than SBRT, but for a small lesion, it will not make a much difference.
I have very less question to you. That's why I'm asking about proton.
Sir, not much difference. It will not create much difference, for sure.
You know, Apollo Proton has put up a nice paper on the early NSCLC in a medically unfit patient. They had some good data also on it. That's the reason I was telling you.
Okay.
So anyway, I think, yeah, the molecular panel report came as L858 mutation positive. Dr. Samir, what is your next approach?
Sir, one point I want to highlight here. So we were discussing whether we should do a broad NGS or only EGFR and PD-L1. So one additional advantage of broad means NGS can be if we think one step ahead. So we have a good data of monitoring with CTC in lung cancer after surgery, and there is a good data.
But you know, Samir, I agree with the CTC. You know, but CTC is something which you'll put yourself into more problems in the sense that you know.
I know, but sir, means like if the CTC is positive, patient is going to relapse in next 3-6 months probably.
But that is, to be very honest, it is not approved. You know, you cannot monitor based on the CTC that the patient is responding or not.
Right.
It becomes very difficult also. So right now,
but maybe the future trials maybe
future is
revolving around that.
I remember CTC is going for the last 10 years. The future is still to come. That's the only thing which I can answer. So my question is that EGFR mutation positive L858, what is the next step? Will you give post chemotherapy or you will give without giving any chemotherapy? Osimertinib.
So if the patient is actually fit for chemotherapy, I would give chemo and then only osimertinib. The patient is not fit, then maybe directly osimertinib.
Okay, so I think we have a lot of data regarding the role of therapy. I will not go too much. There are we have studied so much about the adjuvant chemotherapy. Practice very less in our practice, and we know that the stage B 1B onwards, the data is very strong. And Adora has almost changed the way we look into the practice. But a lot of drawbacks, you know, financial toxicity is something issue. OS is still a thing which has not got come up at all. And Nikhil had presented a very nice slide, but something like which we cannot avoid, you know, talking about is a DFS. You will hardly see this kind of DFS of hazard ratio 0.17, 0.20, and something which is very tempting for everyone to give at osimertinib. So I have one small question is that, you know, Samir, you think this now Adora is now going to change the whole way? We know that we are prescribing. Only problem is that we have to find the patient, like, you know, to give it, right? Any patient from your side whom you are giving adjuvant osimertinib?
No, sir, not yet.
Not yet.
I already told no patient got adjuvant chemotherapy in last 1 year. So definitely osimertinib is out of question. But definitely, sir, if I get a chance, I would offer, because it's actually I want to share one of my patient's experience. So he was my close relative. He underwent a surgery around 3 years back. He relapsed immediately within 1 year. He was EGFR positive at that time, but he relapsed in such a bad state that he could not receive even EGFR TKI. He died within 3 months. So such things happens. Means if the patient sometimes they relapse so bad, they may not get a chance to receive a good systemic therapy. So I think for Indian setting, I think DFS is a good primary endpoint, where in such a case where the high risk of relapse.
Yeah. So I think
for that patient, the first chance is the last chance, I think, for me. Yeah. So I would definitely offer them if there is such a good DFS benefit.
Yeah, there is one question which Dr. Sahu has also put up. Dr. Vikas, can you answer this? What if the patient is having PD-L1 90% EGFR mutation positive?
Truly, like there are immunotherapy which are approved, sir, but the result and all the trials, the details I don't know.
So basically, if a mutation positive PDL1, standard practice is to follow the driver mutation, right? We will not give importance to PDL1 when the driver mutation is so strongly positive. Osimertinib and immunotherapy, normally it's a very dangerous combination because there's an increased tendency to increase the rashes and other toxicities increases. So if a patient has got a EGFR mutation positive PDL1 90%, we should go ahead with the osimertinib only. Right, Dr. Sahu? I think anything?
I think that is the data from IMpower 010 very clearly points to also one more thing, that the patients who had a ALK or a EGFR actually did not benefit much with the adjuvant.
They did not benefit from the
adjuvant atezo.
Even the IMpower 010.
This one.
So I think we are very clear in our thoughts right now. This same thing. IMpower 010. I had a slide where I have not kept it over there, but yes, what Dr. Sahu said is very clear. ALK and EGFR is something which is important to think. So I think important thing is this is the one.
Can I ask a point to the panel? Yeah, this one. You have the slide with you.
Yes.
Go and the things, the EGFR is below the highlighted one and the ALK is below that.
Yes.
If you look at it, if there's a rearrangement, you don't much benefit.
They don't do too much benefit.
Yeah. And the PDL1 status does make a difference.
Yeah.
Sir, what is the cutoff of PDL1? PDL1 more than 10 or 1?
No. More than 1 they benefited, but if you want a real benefit, it's real beyond 50. So in a setting where
you can see here 50. Yeah. This is the pattern. You can see what Dr. Sahu is studying. 50 has got a very strong benefit.
Yes.
More than 1% is the one which is approved.
Yes, sir.
If you see the IMpower,
more than 1% also hazard ratio is 0.6.
Yes, it is positive. It is positive.
Yeah, more than 50%.
Can I ask the panel one thing, Tejinder, on your behalf? With the 2 medical oncologists, and when you are there in Mumbai, where do you place immunotherapy today in the neoadjuvant scenario? Point number 1, with the nivolumab data. And that's what I wanted to first ask, and then where does the panel feel all about the adjuvant immunotherapy today?
So my knowledge about there are so many immunotherapy data coming up in the new adjuvant setting, and I feel it is very promising. The good thing about that thing is that the CR rate, if you see the nivolumab CR rate, the CR rate is in the tune of around 26 to 30%, which no other new adjuvant chemotherapy has shown. How much that is going to convert into the survival as a surrogate marker, we do not know. But the resectability pattern has not changed grossly, but the CR rate has improved a lot with the new adjuvant data, especially with the, I think the new adjuvant nivolumab data has shown a very good CR rate, complete response. So I think it is very promising, very promising.
It is even more. With Nivo EP, it is even more.
Yeah, because the checkmate 816, that's what you are talking of, Tejinder.
Yeah.
And then checkmate 816 is very clear that the CR rate, which is a surrogate marker survival, actually it has increased from 2-3% to around 24%.
Right.
That's one. Yeah. And second thing is the surgical part has become better. The radical surgeries have become lesser, and it has actually, pneumonectomy has actually come down. And that I think does make a difference to me. And adjuvant immunotherapy, especially for the molecular marker negative group, if the money can be there, I think that will be a big thing. Why I'm pushing for neoadjuvant today, maybe the trial is not ripe yet, because you just need 3 cycles. And then if you achieve a CR, you are going to probably achieve a better, longer duration of survival. That's what my point is.
And this Nivo and EP data is very strong, but some 33, 40%, whatever I know. But Nivo plus EP, but it's very promising data. And, I think we are heading towards, this alchemist, I feel, is going back where they're looking into ALK. But, somewhere down the line, ALK also needs to be given very much importance, because these are the patients, they perform better than the EGFR cases.
Yeah. So, Samir, will you do immunotherapy neoadjuvant, given a chance?
I'm very tempted, but right now, like Sahu said, Samir, you answer. Samir is from the big institute, so he should.
No, sir. Right now, at least I want the DFS data.
Come on, take it. So what do you have to say on the adjuvant atezo data?
Adjuvant atezo data, definitely, sir. If the PDL1 more than 50, as you mentioned, definitely yes. More than 1, I think should be discussed with patient.
Okay.
But it should be EGFR negative.
Yeah,
Then
that's
only.
sure. Yeah.
If it is less than 10 and less than 1, then definitely no.
No, I will like what Sahu said is very right. You know, in the present area, we should discuss about the neoadjuvant immunotherapy. We should discuss about the adjuvant IO. There is a strong data at IM Power 010 is a very good study. And I think we have, especially with the PDL1 more than 50%, we should think about giving the adjuvant. The only thing is that finding the patient is very difficult, Dr. Sahu. You're the only one who might get.
Hey, Vikas is there. Who has the right questions?
Yes, sir. Bole, sir.
I think Vikas, your last thoughts on it, because then we can.
Yeah, because your final comment. Yeah, we're already getting late.
So I think the ADURA trial has changed many things. The survival is, I am positive that the survival difference will also come, sir. As far as immunotherapy is concerned, they have made a difference in metastatic setting. With adjuvant also, like promising data is coming, and new adjuvant setting, there is a more CR rate and more in data is required, especially the DFS and OS, sir. So in the whole medical oncology, the lung cancer management is improving from stage 1 to stage 4.
Right. So I have one small question, Dr. Sahu. Cost is a big constraint. EGFR mutation positive L858. Will you replace osimertinib with a first generation TKI?
I will be tempted to, because I have one data to say on the adjuvant gefitinib, those patients who actually took beyond 18 months and those who did not do 18 months, there was a difference. So
I had also given in my practice.
Yeah, I feel if the patient cannot afford osimertinib, I would be tempted. If, as Sameer told, you might not get a second chance. So there is something working. I will take a signature, and that data of 18 months and below 18 months, that graph when they separated.
Have you given in your patient? Have you ever given in your patient? Around 10 years back?
Adjuvant, as I told you, it's very, very rare.
Yeah.
I have not given an adjuvant in last 1 year, so it's very, very difficult.
Yeah, I had given to one of my patients gefitinib, and the osimertinib data was not there. That's a different thing, because patient was around 80 years. I had no other choice.
Okay. So how the duration of gefitinib adjuvant?
2 years. At that time, I had given 2 years. If you see, there is a first generation TKI data is there, but the DFS is not so strong like osimertinib.
Right.
And look at this hazard, Sameer. It is around 0.6. It is not a very. It is not a very insignificant hazard, and the duration
very high,
matter.
very high. Yeah,
So afatinib may not be
same, not so great, around 0.6, 7
Which one?
Afatinib.
Yeah, but toxicity. In the adjuvant, you would want something very, very less toxic. And there is data, at least from gefitinib, from 2 studies, the hazards around 0.6. And it is a cheaper drug. But otherwise, osimertinib is the standard of care that all of us accept now. Maybe I am still waiting for the OS data. Vikas is very sure it will be positive. I would look at the data because I feel that's a data that will interest me a lot.
Thank you, Dr. Sahu. I think we are already running short of time. Thank you to all the panelists. Thank you.
Thank you, sir.
Thank you, all of you, for that lovely thing. And thank you, Gaurav, for always being a sport for a thing which you have limited answers. Thank you, Vinod, for joining us for the first time. And it was great. Just to cut things short and make it very clear on a scientific podium, all of us do feel that we need a biopsy before we want to operate a patient of lung cancer, or we want to give a radical CT-RT or chemotherapy. I think that point we want to be pretty clear. Right, Vikas?
Yes, sir. Yes, sir.
Practice? Yeah. So I thought that was something confusion that happened. I wanted to clear it off, that the panel did agree that biopsy was the way to go ahead before you want to go and operate someone. So without much of a delay, I would like to invite Dr. Akash, and he is going to speak on the optimal management of EGFR positive. It is not EGFR positive. I really hate when these things come in. The mandate was optimal management of advanced non-small cell lung cancer. I think that was a miscommunication. Also, as the slides are there, we'll do it. But what I wanted of Akash was advanced non-small cell lung cancer, 10 minutes, hit how you want to approach every subtype. But please, Akash, carry on. He's a senior medical oncologist from Indore.
Thanks for the invite. Thanks for the invite, sir. It was a mesmerizing group discussion, a panel discussion, and I would hate to put an end to it. So we'll have a brief discussion on EGFR mutated
You can
advanced lung
mesmerize us
cancer.
further for the next 10 minutes, Akash.
Sure. And we'll try to shorten the discussion so that others do not suffer. So CA lung, we know, is one of the important malignancies that we are faced. CA lung per se accounts for a large number of cancers and a significantly larger number of deaths. As we had discussed in the panel discussion before, that a large number of these patients are detected in advanced stages, and hence their outcomes are compromised and their mortalities are higher. In our practice, most of the patients that we see are either stage 3, stage 4 lung cancer. And with the advent of the EGFR, with the advent of molecular testing and targeted therapy, the outcome of a lot of these diseases have changed. So we'll briefly discuss the first line options for EGFR mutated CA lung, which are locally advanced. So we broadly have three options: the first generation, the second generation, and the third generation TKI, with the other options being the combination with BEV and a combination with one of these, with the first generation TKI with chemotherapy. So the slides are restricted to these three options. The third generation TKI or osimertinib as first line is discussed first because it is something that has the best data. So in a patient who has sensitizing mutation for EGFR, and if it is detected prior to initiation of systemic therapy, to give one of the EGFR targeted TKI is the standard of care, and osimertinib is the preferred agent, of course, because of the overall survival data from the FLORA. If we have started on systemic therapy, we either continue with the same therapy or stop and shift to one of the TKIs. Most of us do the latter or add it to the ongoing chemotherapy, which we can discuss. The prime benefit that osimertinib has is that it is an irreversible binder to the EGFR ATP binding site of the EGFR, and it does two things. The wild type EGFR is not very strongly affected, so the toxicity of the second generation TKI is not seen. And second, that it crosses the blood-brain barrier, and hence much of the survival or the data or the benefit that we are seeing is driven by this fact. So we know that osimertinib has three primary things that we need to know about. One is that it inhibits, of course, the sensitive mutations. It inhibits the T790M mutation, so has a broader coverage. It crosses the blood-brain barrier and has lower activity against the wild type EGFR, and hence has lesser toxicity as compared to the second generation TKIs that we'd see as we go ahead in the presentation. So FLORA trial was a landmark trial in the treatment of EGFR mutated advanced lung cancers, in which the sensitive mutations were either randomized to osimertinib versus the first generation TKI. The primary endpoint was PFS, but the data that most of us were interested was that of overall survival. So PFS, when the data first came, we thought that osimertinib would actually bulldoze everything out, because the hazards ratio was around 0.46 with a PFS, median PFS of 18.9 months versus 10.2 months. And all subgroups, irrespective of their gender, the smoking history, CNS metastasis, what mutation that they have, each of these subtype benefited with osimertinib rather than the first generation TKI. When we see the overall survival data, though it was positive, of course not as emphatic as the PFS data was, the overall the hazards ratio was 0.79. So there was a 21% reduction in the risk of mortality or death, mortality because of for any cause mortality. We also see that at 3 years duration, around 28% of these patients were alive and still taking therapy, which I think clinically is a very a relevant point. Even if the though the survival also improves, but that we are able to continue the patients on same drug for a long period of time is in real world very important, because we know that a lot of patients, once they progress on the first line, there may be one of the following factors that he or she may not be able to take therapy. One of those factors could also be relatives and friends who may offer them alternative medicine. So in that case, probably in the real world scenario, that PFS also comes out to be very important, unlike in treatment of such metastatic diseases. Time to subsequent treatment was prolonged with osimertinib as compared to the first generation TKI, and the hazards was around 0.47. When we do a sin of comparing trials and doing a cross-trial comparison, we see that the PFS with osimertinib was around 18.9 months versus 14.7 months in decotinib, and subsequently the other drugs, the PFSs were small. And this PFS and OS benefit, as we had discussed, was seen across the group, except for say L858R, where though it was a subgroup analysis and we may not draw many conclusions out of it, but it crossed unity there. So all other groups actually benefited, and probably the Asians in the subgroup analysis. So when we see the first generation TKI, the point to be noted is that the PFS still remains around 8 to 10 months in the approval trials also, and in the data that we have from the country also. So a shorter PFS. Second generation TKI, so we have two, decotinib and afatinib. Decotinib was, when it was studied, there were two major issues that we had. One was that the study excluded patients with brain metastasis, which forms an important group of patients with EGFR mutated lung cancers. They may have it initially, or they may progress with a brain metastasis. So that was one factor. And the second issue with the drug was, of course, the toxicity. And the third issue that we see in the Kaplan-Meier curve was that when we look at the PFS, the separation of the graphs start far earlier with osimertinib as compared to decomitinib. So though the OS data numerically looks very impressive with decomitinib with 34.1 month, there were two things, of course, with the trial design. It could not be proven statistically significant. And the other issue was that we are excluding a large chunk of patients with brain metastasis, so that also helps the drug. Here, osimertinib we know has a statistically significant difference. So we come to the second generation drug, that is afatinib. We know that it could not show an overall survival benefit. But there are two important things about the drug. One, that it is cheaper than the others, but of course it has higher toxicity and hence falls out of favor. The other issue is that of brain metastasis. So when we look at patients with EGFR mutated lung cancer who have brain metastasis, osimertinib seems as the ideal treatment. The reason is that the drug crosses the blood-brain barrier, and this is a unique characteristic that I think is probably the major characteristic that separates it from the masses. And this was proven both in the preclinical trial, in the clinical trial data that we have and we'll discuss, and in the clinical practice that we see. So in FLORA trial, both systemic and intracranial efficacy of the drug was analyzed. And when it was compared to gefitinib, we see that the benefit was startlingly better. So the hazards ratio in terms of PFS, both in patients who had brain metastasis and who did not have brain metastasis, the hazards ratio was around 0.47, which is significant and eye-catching. So when we see in the period of time, patients who are known or treated CNS metastasis, around 43% of these patients had progression over the course of the trial in FLORA as compared to 90% in osimertinib. This difference was 3 versus 7, pointing out the same thought that osimertinib crosses the blood-brain barrier and gives a better CNS control. So in brain metastasis, the approved therapies are the IOs in EGFR mutated tumor osimertinib, in ALK mutated tumor alectinib and ceritinib, brigatinib, etc. Now the third important point. So I said one was the longer PFS and the OS. The second we thought was the penetration, the CNS penetration, and the third and most important, one of the important things was the toxicity of the drug. So osimertinib, we see is a drug that is better tolerated, and predominantly for the reason that it does not significantly inhibit the wild type EGFR. And hence it leads to a lower drug discontinuation rate as well as a lower rate of dose toxicity. So when we compare this in Lux 7, afatinib, almost 41% of these patients required a dose reduction. In dacomitinib, this number was for 66% versus around 4% in FLORA. So this gives us a visual impression of the safety of the drug. So similar things are represented in the next few slides, and in the with paucity of time, we'll move on. Now, the fourth important thing that we see is that should we sequence them? So a second generation or first generation TKI followed by osimertinib versus osimertinib at first line. We all in our practice are constrained by the cost and the logistics. Putting that one factor aside, which is probably the most significant factor for a lot of us, we see that when we give osimertinib as first line, we give the longest control. When we give another standard of care EGFR TKI, we get a PFS. And of course, in patients whom we are able to detect a T790 mutation, we may offer them the drug again and get a longish survival. But a large proportion of these patients would either not be a fit for second line therapy, or in a lot of our practice would probably default and start taking some alternative medicine. And a chunk of these patients will not be T790 mutation or will not be able to do a biopsy. And hence, like in a street fight, it is always better to give the best punch first. So the other issue that was, so it is a visual representation of the same thought that a lot of patients die after the first line therapy and they receive PAL care only. Some of these patients are not eligible for T790 mutation, so they cannot be tested and hence we could not give them drug. And who are tested, a small chunk of them come out to be positive. So at the end, we are only able to treat a 1/3 of the patient. Another argument of this often quoted is the Geotag study, and we'll very briefly discuss it. Geotag basically was a retrospective study in which patients who had received afatinib first and had then progressed and were tested and were T790 mutation were given osimertinib. There were certain fallacies in this trial which we always call out, was that this selected out the best patients. Patients who were given afatinib had a longish control, but who progressed, but we were able to biopsy them, or we were able to do a liquid biopsy, prove that it is T790 mutation, and then give drug. And because this ideal scenario does not play out in our practice routinely, hence, whenever given the opportunity, we must land our best punch first. So, summarizing, osimertinib demonstrated a clinical and statistically significant improvement in overall survival. The median OS is greater at 3-year time than benchmark. It is the first time that a TKI, EGFR TKI, has translated its PFS benefit into OS. Almost 30% of the patients would receive on this drug for a long period of time, and thus this drug is safe. With this thought, I'll just take a minute of the session and we'll time to learn how we practice. Is that though we offer osimertinib to all patients, but in patients who are not able to take the drug, we give them either the first generation TKI with chemotherapy in patients who are able to take the drug, we offer them osimertinib. Thank you.
Thank you, Akash, and thank you for that lovely talk on how do we need to treat our metastatic EGFR positive non-small cell lung cancers. And all of us do agree now that for the right patient who has the right pocket, osimertinib is a good choice and probably the best choice available at this point of time. And the best drug should be going up front, should be going up first. And that's with that thought, and that's how all of us have changed our practice. We now come to the last part of this academic feast, and Ashish, thank you for agreeing to moderate this. We have Dr. Ashish Kaushal from Ahmedabad, who will be moderating on extensive stage small cell lung cancer. And I request all the panelists to be making it very interactive, and the others in the audience also can participate in the chat, or can also unmute themselves and speak. And I think, Ashish, that should be acceptable because it's a very small gathering, and to get out of all is what the motto is. So for the panel, Dr. Rajesh from Indore, we have all medical oncologists for you. Dr. Deepak, who's again from Indore. Deepak is from Kolkata, who was there for Kolkata for a long time, back to his roots in Indore. So welcome, Deepak, to this group. Dr. Mehlam from Indore again, and Dr. Vijay Vargav carrying the flag from Bhopal. So we have 4 panelists for you, medical oncologists, all of them.
Yeah, thank you, Sahu. Thanks for inviting me. And I think this discussion would be fruitful for all of us. We have 4 panelists, 3 from Indore and 1 from Bhopal. And this is a sponsored symposium. So I'm straightforward coming to the case. He's a 54-year male smoker with no comorbidities, and he presented with a history of cough and dyspnea for 4 weeks. And the basic investigation was done is X-ray chest PO view, and which suggestive of right hilar lesion, and which is a suspicious for malignancy. So you can see the CT scan was done subsequently, which suggestive of hilar lesion. And then we come to the discussion. The patient underwent bronchoscopy by pulmonologist, which suggestive of morphologically small cell carcinoma of the lung. So I'll start with my discussion with our panelists. I think Dr. Rajesh, if you're there, I would ask you, what would be your preference of additional work of how you investigate in a patient you are suspecting for lung cancer?
Sir, this is a small cell patient with small cell lung cancer, and CT is suggestive of locally advanced. So I would like to stage optimally with PET scan and MRI brain.
So in practice, you do PET scan and MRI brains in all patients, even if the patient has been.
Yes, sir. And so if I'm planning for chemo radiation.
Okay, so you will definitely stage with the PET scan and MRI.
Yes.
So anybody is a different talk, Dr. Deepak, Dr. Mehlam, and Dr. Vijay? Any other investigation you will do?
Yeah, I will go for CT scan chest abdomen.
CT scan chest abdomen. Okay. No MRI brain?
MRI brain, if it is localized, then I will go for MRI brain.
Okay. So if the patient is already metastatic, suppose this patient having the liver metastasis, you won't consider MRI?
No.
Okay. Dr. Mehlam?
I think even it is metastatic, I would like to go with MRI brain.
Okay. Dr. Rajesh in favor of MRI. Dr. Mehlam and Dr. Vijay?
Sir, I would.
Please, Dr. Mehlam, continue.
Yeah, sorry. So basically a PET CT if feasible. And even if it is metastatic, I would also like to go for an MRI brain initially.
Okay. Okay. Dr. Vijay?
Yes, sir. I am in favor of MRI brain, even advanced stage, to rule out, to look for brain mets, and that will help me to decide look for brain radiation or further follow up with MRI brain.
Okay, so majority of the panelists would be agree if doing an MRI brain, even the patient is under a PET scan. Anybody was want to do a IAC because this morphologically small cell, but in your practice, do you consider IAC in every patient, or you could just rely on the pathologist suggesting small cell and you'll start your treatment?
In my practice, if pathologist is reporting in small cell lung cancer, I will definitely go for IAC.
You'll get to. So Dr. Rajesh in favor of IAC, and what about Dr. Deepak?
Yes, I will go for IAC.
So small cell you won't start without IAC. Okay, Dr. Mehlam and Dr. Vijay.
Yes, sir. IAC definitely.
Okay.
Sir, if the patient is smoker,
Yes, this
Then
patient
I
is
may, if patient is a smoker, then I may rely on the pathologist. If that is small cell, if she is clear about the histology, then I didn't go for ISC.
Okay, so majority of the in our practice, I think also we do the ISC most of the patient. Only if there is a very clear-cut radiological picture in favor of the clinical diagnosis and the pathology is very clearly shaped. If there is any kind of the confusion or very poor definition, I think it is no harm of getting the ISC confirmation because your entire treatment is going to be modified based on the histopathology. So anybody would be doing any additional test because in small cells, there is some of the data suggests I'm doing a bone marrow aspirations and like alkaline phosphatase to rule out metastasis. Anybody would up to that?
LDH.
LDH, yes, yes. So bone marrow, anybody would do bone marrow in their patients? No.
Okay. I do when there is something of a blood investigation that is pointing towards that. I would do. If a PET scan is also suggesting me that that could be infiltration, I would like to document the bone marrow.
So I think I would agree with Dr. Sao, especially if there is a if you're suspecting anything is myelophthisis in your blood pictures, especially if the platelet count is low, you may maybe even this, particularly if the scan is not picking. I think that would be, I think, my approach.
Yes,
But if there is obvious metastasis and blood profile is okay, I think it's not going to do much change in the treatment part. So what about the biomarkers? Anybody would be do any kind of the biomarkers before starting the treatment? Dr. Rajesh?
No, sir.
Any biomarkers you do in small cell?
No, sir. Not doing any biomarker.
Dr. Deepak?
No, there is no biomarker actually for small cell.
No, no biomarker. No, you don't do any, even a PD-L1, Dr. Vijay?
No, sir. Right now, we are not doing any biomarker for a small cell.
Okay. So I think there is some data on the biomarkers, especially on the TNB and the PD-L1. But in small cell, there is a mixed data. The checkmate data where the PD-L1 doesn't correlate with the response, and TNB is one of the data where they're showing the response in checkmate study. But in Empower studies, actually even the TNB doesn't correlate. And Keynote study, the PD-L1 is a positive patient there, the response. So as of now, I think we agree with all the panelists. There is no clear-cut data, the biomarker-based treatment in small cell lung cancer. So we rely on the morphologically and the radiological version to start the treatment. So this patient, as most of the panelists agree, this patient underwent the MRI brain and was just positive for multiple CNS metastasis, though the patient is totally asymptomatic for the brain lesions. And there is no history of any headache, seizure, or any other brain symptoms. So I think we'll start with, so the final diagnosis comes with the small cell carcinoma of the brain metastasis. And now what would be the next line? So Dr. Vijay? What will be your preference? Do you treat radiation, brain radiation first, or then systemic treatment, or will you consider the systemic treatment first? Dr. Vijay.
I will consider systemic treatment first and look for patient to be symptomatic. Then I will treat.
So you will consider only systemic treatment, no brain radiation in asymptomatic patient. Dr. Deepak?
I will go for systemic treatment first.
Okay. Dr. Rajesh and Dr. Melam, you will agree, or you have a difference in opinion?
Yes, sir.
I will go with systemic therapy first, and after completion of chemotherapy, I would go for radiation.
So I'll agree with the same only. Systemic treatment first.
So systemic treatment first, but radiation after completion of the chemotherapy. So Dr. Rajesh and other panelists would not consider radiation. Okay. So I think the data in asymptomatic.
I'm the only one, Ashish, who's erring towards RT and then chemo. I understand the data is for asymptomatic. Don't do that, doesn't change. But you told multiple brain mets. In the reality, if one conversion happens to this patient, then I think it is a doomsday. So I totally agree. The data is there, but I do not know how comfortable I am. I'm little very uncomfortable.
Yeah. So that is the clinical scenario. I think, Sao, your own experience maybe probably a little guide. But if you see the data, I think most of the patient would be, I think an asymptomatic patient, the systemic treatment we can consider first. And I think, as Rajesh was saying, they may consider radiation depending on the patient, any kind of symptoms or any deterioration. Not even in the seizure, we need to definitely consider immediate radiation. But in asymptomatic patient, most of the data in favor of avoiding the radiation upfront.
And if there are multiple, really does the panel outside the scientific forum does not advise radiotherapy? Multiple brain mets?
That's fine.
Is it that how you? I totally agree. The
Sir,
data
this is a very chemosensitive tumor, and in my practice, we are giving chemotherapy first, and if patient is not responding or patient has seizure or some symptoms, then at that time we are giving it.
Can I ask one more question? Sorry, Ashish panel.
Yeah,
I would like to know, is there any data for the intracranial response to chemotherapy for small cell lung cancer alone?
I don't think.
Anyone aware of it?
So, I think there is a limited data, but if you see the platinum can cross the blood-brain barrier, especially the cisplatin, and there's a data there may be impact response. I think that would be a clinical decision, but if you see the data, if the patient very small lesion, multiple, I think patient is symptomatic, I think our radiation oncologist would definitely delay the treatment. I think systemic treatment would be line of treatment as the data shown. And even in the, you can see in the NCCN and even the extensive stage brain metastasis patient is symptomatic, you may consider systemic treatment. Of course, it's a clinical decision. Nothing is wrong in treating the radiation.
No, I totally back the data, and the data is not there at all for it. I totally back.
Yes. So, considering the treatment options, so now this patient is asymptomatic brain lesions, and we have various data in the small cell lung cancer. The platinum with etoposide is a gold standard in last 3 decades. We are using in our practice. Now the discussion is about any other treatment which could benefit for this patient. So let me start with Dr. Rajesh. What would be your preference of treating this patient? You said the systemic line would be your preference.
Cost is no bar. I would go with immunotherapy and chemotherapy.
Yeah, cost is an academic discussion, so we can.
Then immunotherapy, chemotherapy. But
so, yeah.
I have never used this.
Okay, you have not used. Anybody would be a difference? They will keep the immunotherapy for the subsequent line. They will consider initially chemotherapy alone. Dr. Deepak, Dr. Vijay.
No, sir. Immunotherapy is not therapy which can be saved for further line. It should be given upfront. So the benefit, if it is there, it will be long remission. Patient should be get benefit more and more.
Okay, Dr. Melam, your comment?
So same actually with the first line only immune checkpoint inhibitors also along with platinum.
Okay. So I'll keep this fourth option other, as Dr. Sahu was saying, he will treat with the radiation and then systemic treatment. So I think that's another way. So see the response. I think we all know with the systemic treatment, especially with the chemotherapy, with the various combination, I think we can reach up to 8 to 10 months of OS, which is the data. And I think as Dr. Vijay spoken, using the first line with the best combination immunotherapy with chemotherapy, and not keeping the immunotherapy with subsequent line, I think because the small cell, most of the patient die within a year. So I think using the combination would be the preference. But now, what combination? So we have a 2 drug, atezolizumab versus durvalumab. We have a 2 data of Empower 133, and we have a Caspian data. So Dr. Rajesh, how will you proceed for this patient? Dr. Rajesh, you have to unmute yourself. You have to unmute. Okay. Dr. Vijay, you can take this.
Oh, sir. Basically, this is theoretical discussion for all of us. I have not any hands-on experience of using immunotherapy in small cell variant. But I think we go ahead with atezolizumab with carbohydrate.
So you will consider atezolizumab. Dr. Deepak?
In my opinion, both these options are valid. We can't do cross-trial comparison, but in both these studies, there was a 2-month survival difference, either with durvalumab or with atezolizumab.
Okay, and Dr. Mehla?
Sir, either 1 or 3, like atezolizumab with carboplatin, etoposide, or durvalumab with there's no cross comparisons.
Okay.
Actually.
And Dr. Rajesh, if you can unmute yourself. Okay. So, yeah, Dr. Rajesh.
Yes, sir. I agree with Dr. Deepak and Dr. Vijay.
So the data is there for both the agents, but there is still some of the fine difference. I think I will let you know. Like in Empower, where the atezolizumab is combined with chemotherapy, it's taken in all the corners, no biomarker selection, both the studies. But if you can see untreated brain metastasis, which is excluded in Empower, which is included in Caspian study. The PCI is allowed in the control arm with Empower and Caspian also, but in experimental it is allowed only in Empower studies. And the main advantage of the Caspian is in the control arm up to 6 cycle, where in Caspian it is 6 cycle, in Empower it is up to 4 cycle is allowed. And flexibility of both the platinum, cisplatin and carboplatin, both is allowed in Caspian. So that's, I think, a more real world kind of the clinical practice. So this is a very important, and especially if you see in this patient, there is a asymptomatic brain metastasis and you want to use a systemic treatment, I think the data favors the combination, but I think you can see that Caspian, where the untreated brain metastasis patients are allowed. And this is the summary of all studies, especially the Empower, Caspian, as well as we have a pamlozo data on the Keynote 604, and we have enablement data. So if you see the median OS, which is 12.3 months with Empower and durvalumab, which is around 13 to 12.9, and the PFS is almost similar. Both studies that the patient is very well tolerated. So comparatively, this is not a head-to-head comparison. We know this is a cross-trial comparison. But if you see with this study, I think there is a more real-world use of this agent, especially the durvalumab and the chemotherapy. I think that gives a more flexibility using, because I don't think so we stop the chemotherapy of just a 6 cycle. I think I would prefer if the patient taking chemotherapy, I will consider for 6 cycle. So any comment on that, Dr. Rajesh, from your side? Or how you will take this data?
Yes, sir, agreed.
Any now, because with this data, any of your preference? Because especially you can see the last slide, the more flexibility of the platinum, there is a use of 6 cycles. So do you see there is any difference in your practice?
Sir, I think I still think we can give both any of this, because we have phase 3 trial for about both. But as you said, there are 6 cycles we had given in Caspian trial. I might choose the Caspian trial. Okay, Dr. Deepak, what will your preference?
Seeing this untreated brain mets patients are excluded from this atezolizumab study, I will prefer than durvalumab.
Yes, and Dr. Melam.
Sir, as Sir said, actually, because the untreated patients are excluded, so definitely durvalumab would be a preferred choice at this point, if we see the data.
Dr. Vijay?
Yes, sir. Now you mold all of us towards the durvalumab because
so Vijay, that's take home story. Give radiotherapy, both are eligible for both.
So that's I'm coming to that part. So that's why because this is that's why I've chosen a specific case, because there is no data head-to-head comparison, but this is actually my.
But still, there is some points in favor of durvalumab, especially brain met patient excluded from.
And this is the real world practice. I think I don't stop giving 4 cycle chemotherapy. We all consider 6 cycle. I think this is.
Can I ask a more provocative question to the trial? Yes. Is there any difference of 4 versus 6 in a non-responder? Anyone with a stable disease, if I give 6 versus 4, do I do more benefit by giving 6 cycles?
No.
Anyone can take it.
Yeah.
Because see, if the patient is not responding beyond 4 cycles, giving 6 cycles would not matter much. If there is a response between 2nd and 4th cycle, still the response is continuing, I will probably give 6. That's how I practice. If the 2nd and 4th, the stability of disease there, normally, do we benefit by giving 2 more? That's the moot question which we need to answer. If that is not, the 4 versus 6 question really would not be much of a difference to me. I think I need the panel's opinion. How do they practice 6 and versus 4? Even Akash is there, he can also jump in.
Sir, we give 4 cycles as standards.
In small cell lung cancer?
Small cell.
Small cell.
No, I think I give 6 cycle in small cell lung cancer. In other like non-small cell lung cancer, I give 4 cycle and then plan for maintenance. But in small cell lung cancer, I am giving 6 cycle of carbohydrate.
No, the question is data that 6 benefits more than 4.
So it depends upon the response. If the patient is responding, definitely continue up to 6.
Yeah.
But most of the patients, small cell, they are chemosensitive diseases, so they will respond
Do they
early
keep
on.
continuing to respond beyond 2 to 4 is the question.
So if they are responding continuous 6, if not beyond 4 is stable disease, then not continuing beyond 4, sir.
Okay.
So it's a more kind of the practical judgment, as you rightly mentioned. If the patient is not responding 4, less likely to respond 6, but the data says beyond 6 there is no real advantage.
Agreed.
So 6, you can give 8 or 10 is not really advantage, but your patient is tolerating very well, responding clinically. I think I would love to finish the 6 cycle, and I think most of all of us are doing in our clinic.
And one more question: how many of us practice cisplatin today in small cell lung cancer?
I think
No,
I would be more majority of the patients is cisplatin. I think
you give cisplatin, Ashish?
Yes,
Deepak?
majority of the patients.
Carboplatin.
Carboplatin.
I don't get cisplatin.
Okay.
Carbo, sir. Carboplatin. Most of the patient I use.
Okay. I have also myself changed from cis to carbo now because I feel it's more convenient, lesser nausea. The efficacy is equal. I think I have also shifted.
So anyway, patient
fluid.
Yeah, anyway, patient is admitting for 3 days. So managing cisplatin first, because most of the time this toxicity comes in first 48 hours. So I think we'll manage that. So that's why I'm still strict to the cisplatin. Only thing if there is any issue of any underlying comorbidities, cardiac, where the patient.
Ashish, anything again? Can I ask you anything that compels you to go for cisplatin still, because we have a delayed toxicity as a side effect of cisplatin? Nausea does persist beyond 4-5 days also.
Yeah. So really speaking, till now I think I'm very comfortable. Like head and neck,
because of the comfort level and both are
so
equal.
I am not facing major issues, and like head and neck, we are using cisplatin. So I believe cisplatin is somehow still we are able to manage, and there is no major issue. So we are still in the good standard treatment.
In good performance patient and in early stage especially, I may consider cisplatin. Otherwise, in extensive stage or all other patients.
So this discussion is for extensive. Early stage, definitely cisplatin is the preferred.
Yeah.
Okay.
So there is also data of this Caspian study. I think this is important because this patient is having the brain metastasis. You can see in durvalumab with chemotherapy, the median OS is 12 months. You know, in intent to treat population, it is around 13 months, and the HR is also positive. So compared to the chemotherapy, it is 8.8 versus 12 months. So really significant. The HR is 0.69. While if you see an Empower 113 in the patient, those who have been received radiation, I think the benefit is not there. HR is 1.07. The median OS is actually lesser. It's less. So eculizumab is 8.5 versus 9.7. Though the number of the patients are 10%, but even with the brain metastasis patient, they didn't do well. So I think with brain metastasis patient, I think we have a very clear answer. We should use the combination of durvalumab with chemotherapy. Now, role of the PCI in extensive stage. Dr. Melam, do you consider PCI?
Yes,
suppose
sir.
the patient is no brain metastasis, and suppose the patient having the lung lesion and the liver mets, and do you consider?
Yes, sir. I do consider still PCI, prophylactic cranial irradiation.
For all patients?
Yes, sir. For most of patients, especially who are responding to the chemotherapy. Yeah. Not
Dr. Deepak? Dr. Deepak?
Yes, we do practice PCI in patients who have responded, at least a partial response.
So more than PCI. Okay, Dr. Vijay and Dr. Rajesh?
Agreed, sir.
Yes, sir. We all giving
It has
PCI.
given survival advantage. PCI who is in the patient who is responding with chemotherapy.
Ashish, can I bring in a point here? I think
sure.
PCI, there is only one data which from Japan, if I don't forget it.
That is against the OS benefit, sir. Yes,
Yeah, no. I wanted to make a different point. So the data looks into that if you are closely following these patients up, then you might not do the PCI. But on an Indian patient who's very insincere follow-up, I'd be very comfortable doing PCI. But otherwise, if there's very good patient who would follow up, do a MR once in every 2 months for a brain, then I think you might get away. Ashish, what
yes,
is your
so I think there's a Dutch data. I think on my next slide will take you this answer.
Okay.
So there's a data of the OS benefit. I think, and also you also raise the right points. Monitoring with the MRI, that would be another way. But I think most of the patient, if there is a partial response or CR, I think PCI is still, I think, more preference. But now this is everything in the era where we are only using chemotherapy. Now with the immunotherapy, I think we don't have a standard answer, because in these studies, there is even if the patient who completed chemotherapy and there is a more than PR or CR, I think they're still continuing with the maintenance immunotherapy. So the exact answer we don't know, but in selected patient, I think we are still considering PCI. And what about radiation to the residual primary, Dr. Rajesh?
Sir, I am not practicing this, and I am not aware about the data about local EBRT to the residual trial.
Okay. Dr. Vijay, Dr. Deepak?
Yes, sir. Some of patients which are responding in extensive stage and there is a good response and there is no distance match, then we may consider them for local radiation.
So we have a data for both these things. I think, as I mentioned, it is a Dutch study for the PCI, but you can see in the last paragraph, the immunotherapy patients, I think we have a very much selective, but there is no standard data. But in consolidated radiation, I think still, we do consider in this patient, I think especially those patients. So there is a Dutch studies also. So we do radiation if the patient having more than PR, especially if patient there is residual thoracic primary, and all the other metastatic side is well controlled. So provided this patient is in good performance also. So this is the conclusion for the discussion. We are discussing since half an hour.
Can you go back one slide, please?
Yeah, sure.
Yeah, I think the last line really makes it, and I think all of us do the PCI, but if a patient who's, let's say we have a very high profile patient who's like a high end official or something, a big businessman, big shot, I think we should be aware of this Japanese data because it's a randomized trial, and it does tell us one story that if there is no brain mets to start off with, and the patient can be followed up, and the patient is ready to do a routine MRI.
Yes,
I think this option should be discussed because there would be long-term effects of radiotherapy to the brain. So in the legal scenario, I'll be very, I just wanted to highlight that. That's all.
Yeah, absolutely. I think, but that is really clinically challenging doing MRI. So most of the time we consider PCI.
We should discuss that.
Yes, absolutely. So to conclude this discussion, the durvalumab with chemotherapy is just one of the new standard. Although we have a data with durvalumab also. But this first line durvalumab with chemotherapy is improved OS compared to the control arm. And this is the real world data. Most of the patients, they receive the 6 cycle of the treatment. They also allow the use of PCI in the control arm. And this benefit is across all the subgroup, including the brain metastasis, which is very in around 1/3 patient we see in brain metastasis in our practice. Around 22% patient, they haven't survived even beyond the 2 years. Now we have a 3-year data. It's around 17% with the durvalumab chemotherapy. And the response rate actually with the Empower, it is similar to the chemotherapy to high. And durvalumab with chemotherapy, it's a superior, it's 3 times more than the chemotherapy arm. And another advantage with this combination, after completion of the chemotherapy, the maintenance treatment is actually once in a month, which gives the flexibility, and the safety profile is there with these agents. With this, I thanks to all my panelists for their participation, and I hand over to Dr. Sahu for the final comment.
Thank you. Just last question to you, Ashish. If you have a very good response, the extensive stage small cell lung cancer, there's a very small residual left behind on a PET scan, which is lighting up for the lung only. Would you go for a radiotherapy consolidation to the local site?
Yes, I would prefer. I would give at least 30-10 fraction for residual primary. I do practice.
Yeah, so I think I am also trying to shift toward this type of practice because I feel there is some data, maybe a little bit of PFS rather than OS. I totally agree. I thought that I had to highlight.
Yes.
So anyone wants to make any point?
But I will also change my practice. I will start thinking about
Rajesh, your voice is breaking. Can you come
residual disease? I will also start giving referring the patient for radiation if it is everywhere disease control in low primary is low.
Okay.
Sir, I also have a point, sir.
Yeah, please, Akash.
Sir, Ashish sir wala background bahut acha hai.
Ashish, please share the slide set with Akash so that he can copy paste it and use it. Ashish, take it as a compliment.
So Deepak, it's a virtual background.
Yeah, Deepak, you wanted to.
No, I don't have any comment.
अरे भैया तू आकाश आशीष से कंपेयर मत कर, हम छोटे लोग एमपी के अहमदाबाद लोगों से कंपेयर करेंगे तो ऐसे ही, और दीपक बड़ा सिटी छोड़ के छोटा शहर में आ गया. चलो, with that small things, I just wanted to end up with 2-3 things here. Do all the IOs are not made same? That's what Ashish has pointed out. The trial inclusion criteria is something that we should be taking into consideration if you are a very purist way of looking at trials. What Ashish really pointed out was if there is a brain mets, asymptomatic or symptomatic, if not treated, the data is more towards using Durva. If there is a asymptomatic or a stable brain mets on a patient who has received radiotherapy, probably you have both the options. That's point number one, what I take off it. The platinum is something which I will not consider much, but the data which he put forward is there's more of a flexibility of cisplatinum and carplatinum towards durva, while it was more of a carbo towards the atizo data. Apart from that, the 4 and 6, all of us agreed that the responding patient, we will go for 6. If not, 4 is okay. And there are some panel, even I also do not go beyond 4 if there's not much of a response, but at least 4. So these are the things which need to be highlighted. Last point which I want to make, although it's a sponsored session, is the benefit of a 2 months good enough to the cost is something we need to discuss. But I think at the end of the day, we have to be professionals, give the best advice to the patient, let the patient decide for himself, is the money worth it? That's where we should be stopping, and that's our job to offer the patient the best possible treatments. So with that, I would like to thank all the panelists, all the speakers, and I would like to thank the moderators, both of them, both the speakers and all the 9 panelists who made this very lively. Last but not the least, I would like to thank the sponsor, both Astra and Strand, and definitely the back office of Tarun and his team, who does a lovely job, and definitely Dr. Malvi, who allowing us to use the Bhopal Haematology Society forum for doing this. And thank you, Horizon. You have been always helpful to me. And thank you, everyone. Stay safe and stay. Please keep yourself away from this so-called Omicron. I am gradually thinking to believe it's more like a upper respiratory infection that's going to happen and just going to go away. That's what my more feeling it is. Gradually, that's how we are developing to. Thank you, all of you.
Thank
Bye.
you. See you.
Yeah,
Thank you.
Sana, you wanted to say something before we end off? Sana, you are there? Okay.
Yes, sir.
Yeah, wanted to say something?